Welcome to SIMcast, a podcast brought to you by the Society for Imaging Informatics in Medicine.
Greetings, SIMcast listeners. Today I'm about to introduce someone who cannot be done justice with any introduction, really. I could be recording an entire episode just trying to introduce this person. It is someone who's a giant in the informatics world. It's none other than Dr. David Avrin. I will give a very concise introduction, though, just in case you've not heard the name before. So Dr. David Avrin, MD, PhD, is a professor of radiology and biomedical imaging at UCSF, a pioneer in medical imaging informatics. He's got nearly 6 decades experience in the field. He started with 3D protein visualization as an undergraduate, and then he played a key role in integrating PACS and EMR systems, advancing radiology workflow, education, research, etc. He served twice as the chair of RISC/SCAR, which are the predecessors to SIIM, as well as the SIIM itself. He helped guide the organization from early adoption of PACS to its mature, influential role in the field. He has authored over 50 peer-reviewed papers, 5 book chapters, and served as the editor-in-chief of the Journal of Digital Imaging, which is now called Journal of Imaging Informatics in Medicine. He is a graduate of MIT and Stanford. He trained in diagnostic radiology at Stanford, pioneering the first human dual-energy CD images. His career spans leadership roles at UCSF and the University of Utah, clinical expertise in abdominal imaging, interventional radiology, the creation of UCSF's ACGME Clinical Informatics Fellowship. He has been recognized as a fellow of both ACR and SIIM. He received SIIM's first gold medal in 2020. He is now retired in Park City, Utah, enjoys skiing and mountain biking with his wife, 3 children, and 4 grandchildren. So Dr. Avrin was extremely generous with his time, and we got to sit down and recorded 2 episodes worth of content. You are now listening to episode 2 of 2.
My entire career, up until towards the end of my career, was built on making digital radiology clinically successful. One of the big things we accomplished at Utah, Wiggins and I, was we made every operating room and every conference room in the hospital where a clinical conference would be held digitally accessible. And that was back in the early 2000s when displays were expensive. But we succeeded in doing that. It wasn't until years later that we succeeded doing that at UCSF. And, there are just interesting things about the companies. And, at Utah, we used a web system from one of the vendors that worked wonderful. And it was the same product that we used at UCSF, but it was marketed by a different vendor, written by a different consultant. But the fine-tuning they had done for UCSF made it unworkable in a distributed environment, yet at Utah it worked. And, Wiggins and I are still scratching our head about that one, and Ron. And, when I look back, the profound mentors I had in my career, well, let me just say this, that, even though CT in its first implementation was the algebraic reconstruction technique, which is part of the reason Hounsfield got the Nobel Prize, was not a Fourier-based method. But with my Bose background in Fourier, there was a Professor Bracewell at Stanford who wrote a wonderful book that has just great examples of it on the bidirectionality of Fourier transforms. And the most profound thing, and he is a radio astronomer, and there's a theorem in the radio astronomy world called the projection slice theorem. And you can actually take that undisturbed completely as a whole and use it for CT reconstruction. And basically, Bracewell's projection slice theorem says that if you're in Fourier space, any line goes through the origin of Fourier space, 2-dimensional Fourier space, in a specific orientation, is the 2D transformation of the same line of the projections you get off the scanner. The two are equivalent. If you take a projection at a given angle off the scanner and do a 1-dimensional Fourier transform of it, it is in Fourier space, it's the ray through the origin in Fourier space of all of those values. So you can create a spoke in Fourier space where you know all the values along the spoke by just doing one-dimensional Fourier transforms of the CT scanner projection data, but it gets sparse out at the periphery, which is why noise becomes a limit at high frequency. So you have to do some interpolation, which isn't always perfect. That's what my PhD dissertation was about. But it allows you to understand the transform in a Fourier concept, which again had its basis in MR, which is completely Fourier based with one additional thing, which is the phase concept. But, my sophomore education in circuit signals and systems from Professor Bose made me love that. And what happened in my career as a radiologist, because remember, I still work 2-3 days a week, sometimes 4, depending on staffing as a radiologist. And I was an abdominal radiologist as well as interventional. We can talk more about that later. But in my abdominal interventionalist world, every day I walked into the reading room excited. And I said, this is a friggin' miracle that we can see inside the human body based on Fourier theory. I'm in the process of writing my personal anecdote regarding Fourier because I think he's the unsung hero of the modern world. So many things we use, and he just died a broken man. He thought, I haven't accomplished anything in my lifetime, not realizing that his Fourier series and Fourier transform theory would live 200 years, maybe 2 millennia beyond him. And every day I went to work, and with MR, which I became somewhat adept at, I thought it was a miracle we could see inside the human body. And before I retired, I realized when I wasn't excited anymore because of Fourier and my relationship with 2-dimensional, 3-dimensional imaging, it was time to retire. But it was a good ride, and what made it a particularly good ride was the SIIM organization, all of our people, and all of our projects that we embarked upon, and the youngsters who came along afterward, guys like Marv Coley and others, and you guys.
Okay. So first things first, I've been actually taking notes as you've been speaking. So if you ever saw me looking away, I'm not daydreaming. I was actually looking at my other monitor.
I thought you were looking out the window. I got it.
Well, that too, actually. I was looking out the window. First things first, happy 80th birthday in advance.
Oh, thank you.
I would have never believed you were that close to 80 if you didn't tell me, because Dr. Avrin, you're as sharp as ever and as entertaining and informative as ever.
That's very kind.
Here's to many, many, many years of having you around. I've told you this personally, but I'll say it on the podcast. One of the personal highlights of this past SIIM annual meeting has actually been seeing you at the meeting. I also got to see Dr. Hori at the meeting. And, it's great to see the people who made it happen. However, I will say one of the highlights from today has been learning about those nicknames. Dr. Dicom I'd heard before. Dr. Pixel is new. So here's one of my quick follow-up questions. What other nicknames should we know of? You and others, of course.
Yeah, well, the Dr. Dicom is the good one. And Dr. Pixel was like only within my residency program, but it stuck. And he's a very non-techie guy, but he didn't call me Dr. Voxel, which would have been more into the future. But the Pixel was fine, and I was very proud of that. My kids have nicknames for me. They call me DBDA, which stands for Dumb Bunny DA. And they think I do some really dumb bunny things every once in a while. And that's still my nickname around here, Daddy the Dumb Bunny, even with my grown children and my grandchildren. And I'm trying to think of who else. Sam should have had some nicknames, but Sam was just an amazing guy. And one of my other greatest honors was I got asked to, I think it was the first Sam Dwyer lecture. And I got to do a deep dive into Sam's papers. And, for a Baptist Midwest engineer, he had pretty good vision of the future and just total grasp of the technology. And between his work and Ron's work on the folder manager and Sam's seminal work, you got to remember, storage was so expensive. And, compression hadn't really come along yet or been factored in. And we'll get back to that in a second. But it was so expensive that we had to figure out what to do about the old studies. How long, did you have to keep them disc online versus tape accessible? And he did just incredibly detailed studies based on real data from where he was working into the frequency of needing a prior study and its recall and how many years you had to go back and the cost of that, of course. And Sam was just the ultimate realist. And Ron had this vision of capturing the patient experience again. So this folder manager concept, because networks were slow, right? And you couldn't load all the priors onto the workstation in anticipation per what we call the prefetch algorithm. To this day, we think Kathy Andriol and I and Wyatt have the only solution to the prefetch algorithm that has still never been properly implemented. But it's become less important because networks are so fast and storage is so cheap that, you say, oh, there's a prior brain. I need to see that. Click and it's there. But, you're just too kind. All these people and Gil sitting there looking at the manufacturer, I can still picture to this day saying, listen, what we need is this spigot. We need an image spigot. Do you understand that? And Steve's sitting there and he's got the spigot ready, but they have all these business reasons not to implement it, especially Siemens. And, again, going back to the contrast, to give GE their credit, they did it out of our argument that this is good for public health, and they recognize that. One of the arguments we made that was successful with the Japanese company was we said, if you go to an open standard, you can sell more scanners because people buy your scanners because they'd be happy to buy your scanners because they can install whatever workstation they want. And that partially worked for GE. GE's problem was, this is true. They said, you don't understand, we can't sell more scanners. We're under anti-trade investigation. We're the leading vendor in the world, whether it's China or the US. They said they won't let us sell more scanners. So that argument doesn't work for us. But we buy your public health argument. And I thought that was, a really good corporate stance. I remember them coming around to that. And once GE folded, everybody else came along with them. But those RSNA demonstrations and the similar things that we had at the SCAR meetings and the vendor presence at the SCAR meetings was just tremendous. Okay, next question. Dumb Bunny DA, that's what they call me.
Okay, so since you came back to family, I'll quick fire one here. So now that you said grandkids, I'm assuming there's a new generation of world-class ski racers coming?
I don't know, but they're a lot of fun. We had kids fairly late in life, so my grandchildren are relatively young. I have 3 granddaughters, almost 9, 6, and 4. And I have a grandson coming in September, our first grandson. I would say my oldest granddaughter, first of all, everybody, including the 4-year-old, are competent skiers. And the 2 older girls in particular, the oldest girl's become a very good swimmer this summer. And she's looked like her mom. She's, who was a good recreational swimmer, but an IM swimmer. So IM is doing all 4 strokes. So we've got an 8.5-year-old who can do the butterfly and the backstroke pretty damn well. And so we're watching her, and she can ski anything grandma and grandpa ski with. And the most fun thing is that our 2 older girls now fly alone, and they come to Park City for adventure weeks with grandma and grandpa. And we have a really good time with them. We're looking forward to our son. Our daughter-in-law on that side is an unbelievable athlete in multiple ways. And we have no doubt that grandson Cole, when he arrives, will, as we say in our family, get down the hill just fine.
So, Babe, you mentioned early on how your family life, like your daughter had said, like, oh, if we move, I won't be able to continue skiing. So how else has your family life influenced your career? I know, like you were saying, your wife talks about how, oh, you guys don't know through biology, right? Like, so I'm sure, like, how all these other outside factors kind of have had some influence on your career over the years.
Well, sometimes I thought they were limiting and I was making sacrifices. I thought, these branch points, the 2 big branch points, let's go back to those. The first one, walking away from Stanford, was stupid. And what I should have done was taken their job and then eventually made it work. And notice I haven't named the chairman who told me that. Made it work my own way, because you can always get things kind of, well, you and I had similar experiences at Utah, so you can't always make it work. But I think that one I could have made work. But on the other hand, it exposed me to Jim Moorfield, and I know more about the business of radiology than most people coming to the SIIM meeting. Let's just put it that way. And one of the things I enjoyed in my career, remember, my dad was this hardworking internist. My mom thought I was crazy for going to medical school. My first job offer was from NASA for doing astronaut instrumentation, and I turned it down. And, my mom says, "Why are you going into medicine?" I said, "Well, nobody understood it, but I went into medicine because I saw, like I said, the day I started medical school, I could see 3D imaging, which came out my first year, right? So those kind of things worked out. And the other option I had that I didn't explore adequately is I should have explored going to UCSF with an academic career, staying in the same neighborhood. But the decision not to go to Baltimore, that was really a gut-ripping one. And, I mean, I love to ski as much as my family, and I, grew up in Detroit. I hate hot and humid winters. I love my winters. But I had a lot of respect for my kids, and I really thought my family wouldn't be happy in Baltimore, even though it would have been great for me, and it wasn't commutable. I mean, the thing about staying in Park City after coming to Utah was that San Francisco was entirely commutable. I turned down being Paul's replacement in Pittsburgh because I was living in Utah at that time, and we loved living here, and I couldn't get there without changing planes. But if I could have gotten a nonstop Salt Lake to Pittsburgh flight, I would have. Who's the gentleman who took the job? Had a very good career there. But anyway, that was another one that I passed up. But not going to Baltimore was really a tough branch point for me. But what I found is that I've had another experience of helping my kids who are amazingly successful, all different in their own rights, and none of whom have gone into medicine. My oldest daughter almost went into medicine. This is a good story. Shortly after we moved to Utah, my oldest daughter was a downhill racer, and my son was more of a technical skier, but downhill is speed and guts and being the fighter pilot. And my 130-pound daughter at 16 could leg press 540 pounds. And I said, "Why did you stop at 540? She said, "Well, you can't get any more on the bar." And, downhill racing is about taking the differences in terrain and the bumps and the jumps and anticipating them with tremendous strength. And on these turns, you're pulling 3, 4, 5 Gs. And anyway, about a year after we moved to Utah, she went sledding with her U.S. ski team buddies on an icy day at Deer Valley before the season opened. She broke her back on a vertical compression fall. And fortunately, she's not paralyzed, but it ended her ski racing career. And she was our scholar athlete. So she became a scholar, and she went to a school that was for ski racing. So she was off in the wintertime, and she had to wait 10 months to start at Stanford. So she took a job as a program coordinator at Huntsman Cancer Institute. And I introduced her to one of the trauma surgeons who had gone to Stanford to give her some introduction to the school and maybe give her an introduction to medicine. And she comes down to my office in Scrubs one day and says, "Dad, I'm going to be a trauma surgeon." And, as a senior in high school. So that's all good until the first day of college. She asked me, because I was on the admissions committee, she said, "What should I do about my college curriculum to enhance my chances for medical school?" I said, "Well, the only thing I recommend is taking chemistry as early as possible, because the committees like to see cell biology and all this advanced stuff, which you can't do without taking chemistry." So I get a call her first day at Stanford, and she says, "Do I really have to do this?" I said, "Do what?" She said, "Take chemistry as a freshman." I said, "What's the problem?" She said, "Well, half the class are physics and chemistry majors. The other half are pre-med students, and everybody's too intense. And I worked really hard between traveling and ski racing and my education." She had 2 years of calculus as a ski racer in high school before going to Stanford. And she said, "I need to have some fun in college." And I said, "I agree. You do whatever you want. It's your education." And that's the last word I ever heard about going into medicine. But what she did do is she minored in medical economics and, that kind of stuff, which is big at Stanford. And she knows more about the economics of medicine than anybody I've ever met. And she became a consultant, and she's a lead consultant for the West Coast for the largest consulting company that designs corporate healthcare plans and has 80 people reporting to her. So in her own way, she's gone into medicine, but she's gone into it from how to make it work for people. And she listens to employees while trying to make it cost effective for her employers. We can talk about health. I mean, the thing I'd talk about if we were getting into that whole area is our failure to share images between institutions. And maybe we can even do a second podcast on that. But I know what we need to do, and I just can't get anybody to do it.
It's interesting that you bring that up. I remember when I was at my fellowship in Maryland, they were saying, between Maryland and Hopkins, they went to the heads of the hospitals and were like, hey, there's something like 10% overlap or repeated studies because we can't share. And they were just like 10%, meh, whatever. It's not. I was just like, come on, that's the radiation, right? All the extra work that's somebody else you can have on the scanner. All the things. And I'm with you. I agree. But it's just like, there's all these other barriers. And Mark Coley actually talked about it at one of the annual meetings a few years back, because he was talking about how he was on his vacation in Vietnam with his wife, and he's able to share video of him,
Exactly.
Right? It's not a technological issue. It's a business issue.
Right. Can we talk about this for a few minutes?
Absolutely.
I'll give you a quick summary. So there are basically two big problems. So the first problem, we recognize this at RSNA. The head of the Family Practice Association came to our RIC meeting, Radiology Informatics Committee, which I renamed from, what was it called before? Electronic Communications Committee. I thought that was so dumb. ECC. I hate electronics instead of digital. So we renamed the committee while I was chairman of it. And he came to the committee. He says, I'm coming here on behalf of Family Practice and other similar practice organizations. I'm president of the Family Practice College of the United States. And this CD problem is huge. You have to fix it. So we set out to fix it, and we got a grant from the NIH. Now, unfortunately, this grant was at the time of this maximum interest in personal involvement in healthcare. Okay? So here's what happened. And Ron and Steve wrote this proposal, and the guys at RSNA, Steve and Chris Carr was huge in this. We got this demonstration grant from the NIH, but it was a 2-phase. And the NIH insisted that we solve problem B before solve problem 2 before we solve problem 1. And problem 2 was making images accessible to patients. Whereas my perspective was, patient signs a document at hospital A and says, I authorize you to share my images with hospital B, and then we take care of it for all the care issues, both cancer care and acute care, the acute transfer, right? The University of Maryland Trauma Center in from an outside hospital, body CT on a car accident, bleeder, etc. And so I said, guys, this is really stupid. And so Wyatt was the software architect, Wyatt Tellis, and he told me that 80% of his software effort was identifying and authenticating the patient. And what the design of the project per the NIH, or they weren't going to give us the money, required the patient to be the intermediary in the transfer. And for the patient to be in the intermediary, they had to have access to a personal health record that could store images. Now, what 83-year-old with cancer is going to do that, right? Or their 60-year-old daughter. And problem B was, after we solved this, then you could move images from Podunk Community Hospital to the Mayo Clinic, right? Or to UCSF. And I said, this is going to kill it. And so we did this demonstration project with demonstrations at RSNA, and it never took traction because it was poorly conceived from the outset. But we were trapped between a rock and a hard place because if we didn't agree to do it the NIH way with patient involvement, we weren't going to get the money. But here's how it should work. The first thing is the patient medical record problem number in the United States. So in 1996, Congress passed an act that you and I as physicians will have an identifying number. University of Utah Hospital and UCSF have identifying numbers, as well as outpatient centers and doctors' offices or whatever. And patients will have an identifying number, different than their Social Security number, like all other industrialized countries. And in 1998, Congress rolled back the patient part of it because of a lobby called the Privacy Lobby, which unfortunately includes the ACLU, that having a national medical record number was an invasion of privacy. So let me tell you an anecdote. My ski racer, oldest daughter, consultant, does a semester abroad in Stockholm. And she calls me and she says, I think I have a bladder infection, Dad, kidney infection. I said, well, just go to the local clinic. And she gathers up her passport, her driver's license, and a credit card, walks into the local clinic, goes into the front desk, and says, I'm a visiting student from the United States. I think I have a bladder infection. I need to see a doctor. And the lady says, what's your full name? And they didn't concatenate it. They have first name, last name, middle name, right? Like we did in the DICOM standard. Only mistake. And she says, what's your date of birth? And Jennifer gives her date of birth. And she types in and she gives her a plastic card. She says, this is your Swedish healthcare card for life. And this is your Swedish healthcare identifier. No U.S. Social Security number. Just, the way we do it with computers, right? This is your Swedish healthcare. And said, you're a guest in our country, so no payment. The payment part was minor. The fact she walked into the desk was an unidentified person, gave her name, date of birth, and they gave her a healthcare number for life. That's the way it should work. That solves Wyatt's problem that 80% of the demonstration project was the patient's identity. We once had a patient come into UCSF with acute appendicitis on imaging and exam, and we pulled up her primitive UCSF medical record, and she had already had an appendectomy. And we're saying, what's going on here? So by the time we figured out after 18 hours, her appendix burst, she gets peritonitis, finally gets taken to the operating room. And it turns out that she used her sister's identification because her sister had health insurance. So there is a health insurance component to this as well, right? But, that caused a lot of consternation. So right patient, right side, right organ, all that stuff. So the second thing is, I think the simple solution is, I'll just tell you that I have CLL in complete remission for 3.5 years, thanks to immunotherapy. I have 0 abnormal lymphocytes and I'm on 0 medication. But Wiggins and I could not transfer my CT images over the internet from UCSF to the University of Utah. Wiggins and I could not do it. I had to bring physical CDs. Okay. I had a similar problem with my mother-in-law with melanoma. And so the deal is that any vendor that installs a storage system into a hospital that gets Medicare and Medicaid money should be required, no cost, to provide images on authorized demand. That's the simple solution. And go back to the NEMA example. You guys figure out how you want to do it. We have all these various standards that are pretty similar. We know the format of the images. You figure out how to do it. Now, the patient ID is still a little bit of a problem, but not that big a deal because Wyatt knows how to solve it. But who knows who we all are? Is the pharmacy middleware vendor, and I'm forgetting their name, but they actually provided a for-purchase patient identification software package. Because if you've ever gotten a pharmacy prescription in the United States, they know who we all are. And I guarantee you they have a database number for each of us. But the privacy lobby won't let us use it. So the solution is to put this problem to the vendors and say, if you want to install a PACS storage solution, physical or in the cloud at hospital X, and you're using federal money, you must share images, period, end. And make that the law. And the problem solved.
If I could interject, I couldn't agree with you that should definitely happen. I will respectfully disagree on the characterization that's the failure, because I feel like it's still works in progress. It's been delayed. It's definitely overdue, but I feel like there are still people pushing for it. Everyone thinks it's the right thing to do. I feel like you can only characterize it as a failure once people have given up.
No,
We're not there yet.
I'm saying it's a failure from the time perspective of my career. I'm 79 years old. We've been working on this for, since we started with the portable DICOM format. I agree with what you're saying, but it may not happen in my lifetime. The things that we haven't accomplished, this is the one technical thing that myself and SIIM and the RIC of RSNA have not successfully accomplished yet, okay? But I'm not sure it's going to happen in my lifetime. And you think about that over the next 10 years. Okay?
100%. I'm 100% sold on it. And I will also say, I don't know if you realize this, I'm actually based in Canada. I'm so happy to report that the vision is definitely alive, because there are multiple countries, provinces, etc., that do image sharing. So, because it's reality in other places, I think also fuels the push to make it reality in the United States.
So as you know, I was editor of JDI for a few years, and I got to identify the topic for the annual issue. So for my outgoing annual issue, I did image sharing, and the first invited paper went to Ontario, because I knew that from my early days that there were clinics up by Hudson Bay that were sending images to Toronto to make a very important financial decision about whether a patient needed to be transported by air. And
Absolutely.
that was one of the papers in the JDIM issue on image sharing. And I'm proud of your example, and I use Canada all the time as my example for how to do it properly. Now, do you have a medical identification number?
So we do. It's actually transparent to the patient. The actual implementation will differ from province to the other.
Oh, that's right. Difference, but each province has a method.
But within Ontario, it's usually your health card number as your kind of universal identifier, is how they could tell who you are.
But is that separate or the same as your Social Security?
It is separate from Social Security.
Yeah, that's
number, because Social Security is handled by the federal government.
Right. So the only country that doesn't do this by state or province or nationally is the United States.
Actually, the state of Maine has a statewide MRN for imaging.
Oh.
Yeah.
Really?
Yeah, they instituted this a while back. Bob Coleman, you probably know Bob from back then. You and I were talking about that when he was coming to SIIM and getting that set up because of the image sharing issue and being able to move images around and be able to identify everybody. So they implemented this a while back.
I agree, Mohan, with your very first point you made that this is not a technical problem. This is a socio-political problem.
Absolutely. Now, I was also going to add one more thing. So I don't know if you realize this, not only am I based in Ontario, I'm actually based in Waterloo. I'm talking to you from Waterloo right now.
Oh, okay.
I worked with a whole bunch of ex-Mitra people. I actually joined the domain after they were acquired. So just an invitation.
You were in the big office.
I was in the big office, yes. Past the cornfield.
Yeah, the big office, though. Let me just say one thing. Don't forget what you're saying. One thing I learned on visiting the big office, that there was an invisible barrier in the big office where one side worked for AGFA and one side worked for non-AGFA companies. And that's why the web browser worked at Utah for sharing images to conference rooms and operating rooms, but the AGFA version did not work at UCSF because it was slightly different. And I just wanted to point that out. But I was there when there were 4 people in the office.
Absolutely. I was going to say, open invitation. If you ever feel like you want to come and visit Waterloo, you'll be my guest. I'd be happy to show you.
I'd love to. If you have a format for me to give a talk, I'd love to come.
Absolutely. Would love that. Yeah. I was going to say, we don't have as many cornfields, but I'm sure we're still, plenty busy. The good news is we are still very high on tech, especially when you consider the population. And I would say that the Mitra movement has actually spawned a whole number of startups and other companies that have actually gone on to do some really cool work in imaging, which is really, really nice. I usually explain to my friends as Waterloo usually punches above its weight when it comes to these.
That's right, for sure. Yeah.
I know you were going to talk a little bit more about the future, and I cannot wait to hear more about what you wanted to say, because that's going to be one of my questions is you've been, of course, very involved in cultivating next generation talent. So tell us a little bit more about that.
Well, I would say that that's been my biggest pleasure. a couple names I failed to mention. When UCSF got into the PACS business, we decided, after thinking about it, to hire the entire UCLA team, which included Bernie Wang and Kathy Andriel and some other people that were excellent, and a couple people from China. And that got us started, but it didn't get us going into the clinical. The same time I was involved in developing PACS and involved in what Bill Brody would call engineering as opposed to science, right? Applied science engineering, that Kathy was a great partner for making that foundation, even before we had the partnership with AGFA. But Wyatt Tellis, who's well known to you guys, he was the son of the section secretary administrator for neuroradiology. And we heard about this 10th grader who was developing an imaging educational database for the neuroradiology section. And I'm proud to say that Wyatt's worked for me, for us, since the 10th grade, in his entire career, except for going away to college and getting his PhD. And that's been one of the privileges of my life. And he's contributed much more to my career than I think I've contributed to his. And, there was kind of a jump in generation. I always tried to make myself available. One of the things at the SIIM meeting is I ran into people that I had mentored, and I'm not going to remember all their names, that I co-authored papers with, who came through our residency program or touched in other ways. And another guy who I didn't really mentor, is more of a co-equal partner, is Raim Geis. But he was the visionary who was able to begin implementing all this stuff in a private practice environment that covered, the northeastern corner of Colorado and southern Wyoming and Kansas. Truly the vision of a distributed digital radiology practice. And then I trained a lot of radiologists with and without interest in digital imaging. And, besides being an abdominal imager, I was a pretty competent interventional radiologist, which was something I discovered in my residency before there were fellowships in interventional radiology, that I was good physiologically and I was okay with my hands. And the reason I was good physiologically was that I worked my way through medical school writing software in a cardiac surgery dog lab. And I got sucked into the operating room when the surgical nurse was shorthanded. And as a medical student, I probably did 50 mitral valve replacements on dogs. And I became very physiologically comfortable. And as a intern and resident and interventional radiologist, I was convinced that nobody was ever going to die in my procedure room. So, but I never was formally trained in interventional radiology because I went before the fellowship. But at UCSF, there was a shortage because of sabbatical. And they said to me, "You do interventional radiology?" I said, "I do it, but I don't do academic interventional radiology." They said, "Well, how about if you sit for the exam and we proctor you?" And I said, "Okay." So to varying degrees over the last 20 years of my career and at Utah, I did a lot of interventional radiology, and which is far away from digital, except the rooms became digital. But the story I like to tell is when I was teaching my ski racer daughter to drive, and she was making comment like, on Interstate 80, "Dad, I go faster on skis than this driving." And I said, "Well, yeah, but you're not in a 3,000-pound vehicle with other people around. So you have a lot of responsibility here." But she said, "Why are you so comfortable teaching me how to drive when Mom's so uptight?" And I said, "Well, I spend a lot of my non-digital time at work teaching inexperienced people how to do dangerous things. And I loved teaching trainees to be comfortable doing interventional radiology, whether it was at San Francisco General with the Knife and Gun Club or trauma cases. And that was kind of the other side of my career that people at SIIM never see. And I worked with some great people like Bob Curlin and felt like I was a pretty competent, I put a lot of people out in the field as interventional radiologists that I helped train, besides abdominal imagers where, it was all about CT and MR. So besides the mentoring of anybody who came through SIIM and the students who came through SIIM, whether they're from UCSF or elsewhere, I felt a tremendous kinship with. and responsibility and an investment in the future, because I knew that these were the people that were going to make all this stuff work. And as I said, everything works except the image sharing. And late in my career was the whole transition to AI. And remember, my computer science 1 instructor was Minsky. But Minsky didn't believe in AI, but he didn't believe in AI for the same reason that Sam didn't believe in AI, because he didn't think that the components were up to it, that the concept was okay, but that it was something that wouldn't happen in the foreseeable future. And late in life, in an interview before he died, which is just a couple of years ago, he came around to saying, I think now we have the technology that's possible. And that gets to the whole issue of the speaker that we've had at SIIM a couple times, called it's not the vanishing point, but it's the book, begins with a D, this crossover point where density of memory and speed of computation will equal the human brain. And so that's the thing I've seen through my career, from these early days of, geez, how are you going to make one digital picture cost effective, to where the entire world of imaging is digital. I can go in my phone, or if I had a newer phone, I'd have a 15 megapixel camera. Unbelievable. But the mentoring has been multidimensional, both in doing radiology as a diagnostician, doing radiology as an interventionalist, and most important, doing radiology with it, trying to advance digital tools. And like I said, one of the most fun things we had, one of our best projects, was the paper that Kathy and Wyatt and I wrote about the proper way to do prefetching and how to identify what's a relevant prior exam, things like that. And lots of medical students, Andrew Nguyen, including high school students, Andrew Nguyen, most exemplary. And he actually presented, and I always had my students be the presenters, presented some interesting work we did on SIIM on image sharing way back then, looking at protocols like COBRA and things like that, with Corba, I guess it was Corba, CORBA, that were before the internet too.
Wyatt is going to be one of the guys I know who's making the biggest impact while being the quietest person on the biology. That would be a different topic for another day, but he's just a great guy. That's all I can say right now.
Oh, yeah. He is special. Oh, I do have one other thing I want to contribute. So late in my career, that's not known to people in SIIM, people at UCSF approached me to start the UCSF version of the ACGME approved fellowship in clinical informatics. And so the last 5 years of my career, I had a joint appointment. And again, this is through Dr. Wachter and a guy named Blum. And that was amazingly satisfying. So this took me out of radiology into the broader aspect of clinical medicine. And I had great satisfaction at the end of my career, where I was able to see things from the perspective of those people who wander into our imaging room or call me up and tell me about the imaging on my patient. And I developed, going back to my dad being an internist, I developed a great appreciation for internal medicine with this effort of trying to make digital doctors for the future. And so that was kind of a surprise. And I actually wrote the document for getting the UCSF program approved, and every place has an individual document based on the resources they can bring to it. And one interesting experience, Prasad, I'll share with you, that I had at Utah was when I came to Utah, I had a joint appointment in medical informatics, and Utah was one of the pioneers in medical informatics. And I was on the curriculum committee and the requirements committee. And I would not give anyone a PhD in medical informatics who could not write one line of code. I just felt very strongly about it. It's back in the early 2000s. And they said, well, half our people come with a technical background and half don't. I said, well, I'm not worried about the ones that come with a technical background. I'm worried about the half that don't. And I can't give a PhD to someone who can't write a line of code, or at least SQL or something like that. He said, well, we had a guy like that, but he left, got recruited away. He said, if you want that to be a requirement in the program, you have to teach it. So from 2005 to 2007, a couple graduate students, medical student and a graduate student, both with computer science undergraduates, And I taught all of the non-technical background PhD candidates in medical informatics at UCSF, introduction to programming using Java, object-oriented programming. And there was no final exam, but there was a project requirement at the end that they could do individually or in teams. And it was the most fun, most amazing experience. So between that and being the initial founding program director of the Clinical Medical Informatics Fellowship at UCSF, which was really a nice ending highlight of my career, I got to kind of transition to the broader area of clinical informatics, which helped me with JDI. And I tried to bring that to the journal. And really, the only problem with the journal was finding reviewers. That was just a terrible problem. And you guys, neither of you are in academics, but I'll just say that if you write papers for publication, I think you have an obligation to review papers. And that's where the rubber meets the road. And that it made the journal editor job very difficult. And it was also transitioned to AI, which, in spite of my first introduction from Professor Minsky and I did a lot of expert-oriented programming, particularly regarding personnel scheduling, but I was not a machine learning, large language model expert kind of guy. And half the papers we were getting to the journal were in that area. And it's a little out of my wheelhouse. And also I had tremendous difficulty finding good reviewers.
As somebody who gets tapped for reviews, I always do my best to try to review every paper that they send. And I got one on something dental, and thankfully my sister's a periodontist, so he was able to refer me to somebody who's a academic dental person, and he was able to take over that paper, which was great. We need to get other people, other fields involved with this stuff. But I want to ask one last quick question. You mentioned SAM, and in talking with Steve Horry, he was talking a lot about Sam as well. And for the people that don't know Sam, and I never met him, Sam Dwyer, we have a lecture named after him. And clearly he was very influential in everything. And one of the things that struck me when talking with Steve was Sam, I don't know if this was intentional or not, but he seemed to position all of you guys at different spots. Steve was saying, like, well, Sam said, oh, well, maybe you should talk to this person over here. I've already got someone talking to that person over there. He seemed to kind of like move people around and, like you said, like building the future. Was that your experience that he seemed to be moving things?
Yeah. I mean, Sam, like Wyatt, they're very unbelievably modest people. Sam was a little more outgoing than Wyatt in his ability to arrange people. A guy I met in college at MIT became the NASA administrator out of JPL for all the deep space probes. And he was a guy like that could put everybody in their proper role, And Sam was the ultimate NASA-style team engineer. You could picture him as launch control for Chris Kraft in those, moonshots. And Sam was just like that. He knew his technology so well. I never heard him raise his voice. I never heard him say a bad word about anyone, but he was the ultimate team builder. And he had an incredible, for a going back to what Bill said to me, you can't do technology in medicine unless you're an MD. Sam was the antithesis of that. That if you do a survey of educated people, we won't get into a political argument about that, but if you do a survey of educated people, that 2 of the 10 most important inventions of the 20th century in medicine were CT and MR. And 5 of the most important inventions of 20th century in medicine include the discovery of DNA, antibiotics, and there was one other thing. And, Sam was the kind of guy who contributed to that profoundly without being an MD. And he was just the ultimate team builder, and he knew his part of the storage technology so well, like this prefetch problem, the percentage prefetch problem, the tail, even the thought that I need to calculate this. He was a specs and requirements guy, requirements and specifications guy. He was like the perfect mirror image to Gil Yost, who was sitting there early with the fancy workstations, and this is radiology of the future. And, Gil became president of RSNA, but, he was the spigot guy, and he said, this is how I want to practice radiology in my reading room. And we have all these scanners that make digital images, and it's just stupid to put them on film. And, for me, I had the fortunate benefit of everything merging for me and just having this wonderful career that fell out of happening to take this interesting seminar in 1966 on digital imaging and the repercussions it had. The most interesting aspect of digital imaging is medicine. And, nobody foresaw the CT scanner. Everybody said, gee, wouldn't it be nice if we could see three-dimensionally into the human body? And it was all about catheters and interventions. And, but in those early days, if you had a patient with brain trauma, head trauma, and you were worried about a bleed, you had to do an angiogram to see if the vessels were displaced from the interior of the skull. I mean, so primitive, and pneumoencephalograms instead of CT, that you guys who weren't even born at that time, let alone seen those procedures or done them yourself, can't really appreciate the impact that old Fourier and the ejection slice theorem and all that stuff had on the world of medicine today. And the era we lived through, where we saw the impact that imaging had on medical care. Because when I went to medical school and you took physical diagnosis, you examined the patient, and then you decided what tests you need to evaluate the patient, and then you made a list of differential diagnosis based on the outcome of his tests. Today, if you come to the emergency room with a certain set of complaints at the desk, you go to the scanner, before the physical exam. The CT and MR made the neurologic exam obsolete. And it was just a wonderful era to live through with the benefit of this great technical education I had as an undergraduate and my mentors like Bill, who encouraged my interest in applying technology to medicine. And SIIM, SCAR, RISC have been the most rewarding. And between Bill and Ron as personal mentors, in addition to all my wonderful friendships that I established through this organization, just the absolute highlight of my career. Die and go to heaven.
Absolutely amazing. Thank you so much for your time. It's really been incredible. So much pleasure.
Oh, and I adore you guys. And it was a heartwarming experience to be at the meeting a few weeks ago. Just absolutely heartwarming. You guys keep the faith.
Absolutely.
And absolutely. I miss you. I always look forward to dropping in on you. And we didn't have enough years to overlap here, but I trust you're doing well and you're happy. And that's all that's important.
Thank you, sir. Yeah, I am. Been good. Better in many ways.
SIIMcast has been brought to you by the Society of Imaging Informatics in Medicine. Please visit our website at siim.org for more information and educational content, including webinars and an archive of prior episodes. Please follow us on Twitter at sim_tweets. Thank you to our listeners for your continued support.